13, 14, let's say. So what order are we going to present? You go this way? Or we go this way?
You want to go first? I can go I'll go second.
Who's going to go first? Doesn't work. He wants to go first. Okay, who's going to go second?
I can go second if you want.
Second, who's third?
I can go third.
Third,
I'll go fourth.
fourth.
I'll go fifth.
Yeah. So you know your order, okay?
Mine's,
Okay, okay.
I'm like explaining a little
Okay,
bit of
so-
like angioplasty and stuff.
Okay, yeah, that's fine with me.
Okay.
So whoever
She's
wants
also
to.
explaining PAD, which will be a good.
Okay, all right, okay, so,
I'll go last.
1,
Yeah.
2, who's 3? 3, 4, okay, 5,
5 and
6.
6.
Okay, all right, very well.
And we're recording, everything's good.
All right, we're good. Any person on that?
Not yet. There's just one spin so far. It's us. We'll give them some time to log in. Or do it.
Yeah, give the 5.
Yeah, no problem.
Yeah, 5 minutes.
You're like somewhere.
Give about 5 minutes.
All right.
Now, Dr. Shahreyar,
Or wait, you're
you have a phone.
Am I going first or is she going
Hey,
first?
first.
Which one?
It's between you and Cristo.
No, so, now,
You want me to go first?
Then her.
I don't have a case. That's why I'm just doing our current guidelines.
Sorry, he's last, or he's second to last, I'm last. You're after, or you're after him, or you're first?
You're after Cristo,
I'll
you're
go
1
first,
or
I'll go
2.
first.
he'll go first.
Let's go first. Let's
because
go.
I-
Yeah, just go first. Okay, so yours
Where's
is
Dr. Shahreyar? You got a phone, see, connect Dr. Shahreyar, 3 or 4.
which one was yours again?
6, 7, 3.
Which one was yours?
Just 1 second. 3 over the top, 65.
This one. Okay.
4, 2, 9.
Okay, so did you want to explain these cases? Remember, I have those 6 cases that you were discuss? So I have, I can like,
Let's see.
I can generally go over them.
Hey, Sangade, we can see you now, sorry.
Hey, Dr. Sangade.
Just, I'm calling.
Dr.
quick.
Shahreyar.
Yeah.
Good morning.
Your mic is off.
Yeah, I was calling you guys to come to the place physically, but I'll just join online, okay? How's everybody?
Good morning.
Yeah, volume's up. Mic's on. I'm gonna share the screen. No, camera's here.
So I'm sharing with 75 minutes. Recording.
Yeah, we're recording.
Ready?
Yeah. Let's see. Oh my God. Yes. Later.
Dr. Shahreyar, can you hear me?
Is it
I
working?
can hear all of you very well.
Very
Go
well.
back.
Okay, I'm gonna get started, so for sake of
Here,
time,
I'm
okay,
trying to share the screen.
and we'll get
And I want to share this. Share.
um,
And then I'll zoom over. So now his presentation is,
Are you guys at the new location?
yes, we are.
should be up
Yeah.
already.
We're-
Good, good. Well, next time I'll be there.
All right, very well. Okay,
Dr. Sangade, you can see this?
Very well, very beautiful.
so welcome to the Global
you can
Medicine
do-
Foundation.
Yeah, you can go
Global
down.
Round Rounds,
You can use the arrows
For
or-
September. We're excited to have you here today, from Berkeley and other parts of the world. We need to, first say that the Global Ground Rounds was generated as a means to exchange ideas, not only within the United States, but outside the confines of the United States. We know that healthcare is difficult in certain parts of the world, and our ability to share our experiences here in the United States with some other underprivileged societies will prove helpful. We also do know that where patients practice in other societies, they work under adverse conditions. As a result, we also do see that they come up with creative solutions to helping find problems or solve problems. In my travels across the ocean, I'm usually amazed at some of the ways that physicians across the pond come up with creative solutions because they don't have the resources to manage their patients like we do here in the United States. We're quite wasteful in the United States, but that's another story for another day. Again, our goal here is to try to exchange ideas to ensure that we work and to minimize or decrease the divide between the continents. Today is a special day because we have a host of medical students, and I've made this session today completely medical students centered. They will present interesting cases that would be helpful in enlightening us on some of the basic things we need to see. We do see patients undergo or suffer in their day-to-day lives. So without further ado, we're going to get started, and we would start with our first presentation in a minute. And our presenter is Dr. Azeez, and he'll be talking about critical limb ischemia, and he'll give us a specific topic in just a moment. Again, this is our new location for the foundation. We're at number 109 Sullivan Road here in Glen Morgan, West Virginia. And next major conference is next month in October, the Endovascular Conference for Africa and Rural America. We hope you will join us on that platform too. I'd also like to say give thanks to our collaborating partners in this venture, Uzuma Foundation, which seeks to improve healthcare disparity in Africa, and also the Edward B. Dietrich Vascular Society, where we have to work with many other vascular surgeons trained by the renowned Dr. Edward B. Dietrich, and the International Society of Endovascular Specialists also. So, Dr. Azeez, are you ready to present?
Yeah.
Critical limb ischemia management in rural hospital settings. Blueprint for success.
Yeah, so I just want to start by thanking Dr. Singleday and everybody joining for giving us the platform and allowing us to speak. So I'll be starting with the presentation on critical limb ischemia management in a rural hospital setting. So the blueprint for success. So we have no financial disclosures to present, and we have no conflicts of interest. So we'll begin with the abstract. Critical limb ischemia, CLI, is an advanced form of peripheral arterial disease that is constituting a major healthcare problem worldwide. Poor management and delayed presentation of patients with CLI can result in major amputations. The primary treatment strategy in CLI revolves around whether the limb is salvageable, worth saving, feasible for revascularization, and the risk to benefit ratio of revascularization. Thorough clinical evaluation, appropriate workup including ultrasound, CT angiography, and catheter angiography are essential in the preoperative planning. Enormous challenges in many rural hospitals lie in the availability of vascular surgeons and available resources for CLI treatment. Creative thinking outside the box and utilization of available resources and collaborative relationships with hospital administrations are crucial for success. So we'll begin with the background. Critical limb ischemia is the most severe form of peripheral arterial disease, or PAD, in which significant arterial blockages lead to limb necrosis and gangrene. PAD affects over 200 million persons worldwide, with over 12 million Americans affected, and over 200,000 amputations per year in the United States alone. In certain global communities, amputation is the only primary option, which constitutes 65 to 80% of primary amputations in some developing countries. The clinical presentation, patients will present with chronic ischemic pain, rest pain, ulcers, gangrene, and it has a minimal duration of 2 to 4 weeks. The pathology, or the underlying cause, is atherosclerosis with advanced calcification of vessels. This includes multi-segmental occlusions, which include the aortic, iliac, femoral, popliteal, and tibial arteries. Risk factors include genetics, smoking, atherosclerosis, hypertension, and sedentary lifestyle. Some of these are modifiable risk factors, and some of these are non-modifiable, such as genetics. Treatment strategies include medical therapy, endovascular therapy, which has seen significant improvements and evolvement since the 90s, hybrid therapy, and open revascularization. And of course, medical treatment can include lipid-lowering medications such as statins. And so our approach in rural West Virginia, the patient encounter begins with a thorough history and physical exam. We then move on to arterial Doppler studies, including ankle brachial indices, which is the ABI. We then go to preoperative CT angios, and then we finally go to the catheter arteriography at the time of intervention or during the operation. And this is to evaluate for marked tibial calcifications. So when is endovascular therapy necessary? We use it to improve blood flow to the fem-pop regions, to improve straight line flow in order to improve chances of limb salvage, and to balance a risk-benefit ratio of prolonged intervention in contrast to patients with comorbid conditions. We avoid distal embolization during endovascular interventions and aggressive interventions to solve distal embolization issues. Our considerations for vascular access include contralateral or ipsilateral common femoral artery access, retrograde popliteal access, pedal access, brachial access, radial access, and axillary access. So next I'll move on to treatment options and cases. So we'll show a case of plain balloon angioplasty. We also have cutting balloons, intravascular lithotripsy, and then I'll show a case with stenting of bare metal, nitinol or covered stenting, and atherectomy, and then percutaneous mechanical thrombectomy, thrombolytic therapy, and we also have a case for hybrid embolectomy, angioplasty, and stenting. So first we have our case of plain balloon angioplasty. It was a 33-year-old female with severe right common iliac artery occlusion, and you can see the images below. Our plan was endovascular therapy with angioplasty and stenting of the common iliac arteries. So on the leftmost picture, you can see occlusion of the right common iliac artery. In the middle, you can see our process of ballooning and stenting. And on the right, you can see perfusion restored to the common iliac arteries. Next, we have a case with covered stenting. An 82-year-old female with right common iliac artery occlusion presented. And our plan was right common iliac artery cannulation from the left brachial approach. So this was an interesting patient. We tried to go from a retrograde approach through the common femoral artery, but there was excessive calcifications, so we couldn't proceed that way. So we had to approach from the left brachial artery, which is in her left arm, and cannulate all the way down into the right common iliac artery. And then as you can see, we restored perfusion with stenting on the right image. So that was a really interesting case. Next, we have atherectomy, a 78-year-old female with plaque obstruction in the right fem-pop region. Our plan was atherectomy of the right fem-pop region. And I included a gross image of their limb. Here you can see that it might lead to ulcerations or gangrene. You can also see the plaques that were removed, and you can see the obstruction they were causing, as well as the perfusion which was restored. Next, we have percutaneous mechanical thrombectomy, a 34-year-old female with severe right brachial artery occlusion. And our plan was percutaneous minimally invasive thrombectomy. So here you can see images of the occlusion in her arm. This was her right arm. And then you can see the perfusion which was restored after mechanical thrombectomy. So we removed thrombuses in this patient. And here we have hybrid angioplasty, stenting, and embolectomy, which is a combination of both. We had a 69-year-old male with fem-pop plaque obstruction and clotting, and our plan was a hybrid therapy with retrograde popliteal artery approach. So you can see on gross imaging how many clots and plaques were removed, and you can see the occlusion it was causing, as well as the perfusion restoration that was obtained afterwards. So these patients can have extensive amounts of clotting and thrombuses both together. And we have another case of hybrid angioplasty, stenting, and thrombectomy. This was a 55-year-old female with right limb aortofemoral bypass, thrombosis, and stenosis. So our plan was thrombectomy and stenting. And you can see their CT on the left, as well as the occlusion in the middle left and middle right images. And then on the rightmost image, you can see the perfusion restoration as well as the stenting that took place. And so one thing that we want to discuss here was the BASIL trial, which is a famous trial. It stands for Bypass versus Angioplasty and Severe Ischemia of the Leg trial. And in this trial, they found that endovascular therapy appears equivalent to bypass. They found that the limitation was with plain balloon angioplasty. It was the only method for endovascular therapy. And there was a 20% technical failure rate at the time of the trial, which has improved with time. Results are better now with improved balloon profile and intravascular lithotripsy. And they also found that bypass is more debilitating. So the take-home message, critical limb ischemia is treated with endovascular therapy, and it has high technical success rates, over 90%. There's low peri-procedural mortality rates, less than 2%, and there's low complication rates, less than 5%. The 1 to 2 year limb salvage is over 80%. So in conclusion, endovascular therapy is useful in the management of critical limb ischemia. Hybrid open revascularization options can provide great success in some advanced cases. Rural hospitals face financial difficulties with capital investment and CLI programs. Vascular surgeons in rural settings must have creativity to make interventions feasible with limited resources. And vascular surgeons and rural hospitals administrators must have financially prudent strategies to make CLI programs viable. And that concludes the presentation.
Dr. Azeez, nice talk. Any questions from the audience? Any questions, please?
So the aortic bifemoral bypass, that was stented? You guys did something inside the body?
Yes, she had an aortic bifemoral bypass with a left limb that was occluded. And we did embolectomy and did find critical stenosis at the bifurcation on the left. Now you couldn't leave that alone, so we had to kind of keep it open. So keep it open, we had to put a covered stent. That's a good indication for covered stent because a plain stent may not be strong enough to keep it patent, so we put a covered stent, and that worked out well. I think we had another patient within a week or two of that event that had similar problems. And sometimes patients present with severe ischemia of the lower extremities and have bad problems. We'll discuss that as we go. The concept of critical limb ischemia, we know they have PAD, but it revolves around their problems getting so worse within a 2-week to a 4-week period that if you don't do anything, there's a higher risk that you'll lose their limbs. Again, we're fortunate, even in the rural setting, that we have technologies to provide care for some of these patients. Other parts of the world where the technology is not available, the primary treatment option may be an amputation. If you don't have vascular surgeons or surgeons with vascular experience, then it becomes very problematic. In certain parts of the world, the amputation is, like I said, first and only option for some of these patients. And our travels between United States and Africa, we're trying hard to change that dynamics. How can we do that for critical limb ischemia? We need to train, because it's a great efflux of physicians away from different parts of Africa, for example, seeking better opportunities in America, UK, Australia, whatever. So there's a great efflux. So now the remaining physicians, there are very few vascular surgeons in say, Africa, very few. So how can we increase the number of interventionists potentially to make that better? Because the population is not getting less, it's getting more. For example, the population of Nigeria is 212 million people. And it's estimated by 2070, population might approach 500 million. It's a lot of people. And you know, if you go to India, 1.3, 1.4 million, you know, so, you know, China, there's a lot of, the world is explosive. And so people get older and they will develop problems. PAD is not isolated in the United States, it's a worldwide problem. 200 million people, it's a rough estimate of people with PAD globally. And amputation, again, in the United States, about 200,000 amputation per year. The difficulty with amputation is sometimes in the United States, even as advanced as we are, sometimes some persons don't do the simple task that he had mentioned. i.e., doing a pre-op test to see what the circulatory status is before they offer amputation or offer treatment in ends that have back problems. So it's important that in a rural setting that the physicians doing intervention have a good rapport with the administration of the hospital. So so they can work out the logistics of making sure that we can provide care for limb salvage. Again, it could be cost effective for the hospital. If just because there are technology available doesn't mean you have to use that technology all the time. So that we have to be selective to pick the right procedure at the best cost to give us the best option. Or similar options. So that's why we go with balloon angioplasty, atherectomy, open hybrid intervention, bypass if necessary to save a limb. A concept we'll talk about also when it comes to critical limb ischemia is a concept of relative ischemia and absolute ischemia. It's important. If you have no flow to your lower extremities for about 8 hours onset, from the time your pain starts, you're in that area of relative ischemia. If you've never had a problem with PAD before, all of a sudden you become pulseless. You have to remember the 5 or 6 Ps: the pain, pallor, hyperthermia, pulselessness, paresthesia, and paralysis. If you have 3 of those, especially pulselessness, you have a problem. You can't sugarcoat it. When you examine a patient, they don't have a pulse. They complain of leg pain that they've not had for a year or 2 years before. It's new onset leg pain. That should get the light bulb on your brain that it's not sciatica. Because again, there are some things that mimic arterial disease. So, and we've seen that where patient comes to the emergency department and the doctor feels, oh yeah, you have pain in the leg. Oh yeah, you have sciatica, when they indeed have no flow, no blood flow to the limb. And if the patient trusts the doctor in the ER and goes home with a diagnosis of sciatica when they indeed have no blood flow to the limb, what's going to happen? Think about it. They'll lose a leg because what's going to happen, that portion of relative ischemia now becomes absolute ischemia. When it becomes absolute ischemia, the blood flow to the nerves gets completely shut off. So and when you look at the patient clinically, how can you identify that the patient has a problem? As a clinician, you tell them to wiggle their toes. If they're able to wiggle their toes, they're still in the point of relative ischemia. If the one limb they can wiggle their toes and the other limb they can barely do anything, then you know they're approaching absolute ischemia. So time is of essence. I have had my practice, somebody with absolute ischemia 4 days after still do well, because you go in and improve the flow and you can still be. I had a great case many years ago of a patient that presented with popliteal entrapment syndrome. And the patient did have a absolute ischemia, We went in and found that the vein was compressing on the artery and had no flow, so restored flow. With some work, she was able to restore flow, and she was able to get. She had a drop foot, and over time she got better. So, but we don't want to be careless. You don't want to tell your patient that they're okay when they're not okay. So again, fundamentally, as young doctors in the making, you have to do what? Number one, when you see your patient, what do you have to do first? History and physical. 90% of the time, the patients will tell you what the problems are. You just have to listen. Then you examine them, figure out what the problem potentially is before you start ordering the tests. Okay, because again, healthcare is expensive in America. It's expensive in other parts of the world. So you don't want to order a myriad of tests, a plethora of tests, when you could narrow the problem very easily with history and physical and order a single or targeted test that will solve the problem, and the patient can now get the good results. So extremely important. Relative ischemia, absolute ischemia. Again, if you have no pulse, they have pain, the leg is pale, so you don't have big genius. That's the problem, it's an arterial problem. Now, if on the other hand, they have complaints of pain for 6 months, then all of a sudden, they get worse. And you still examine them, do all the things you need to do, and you find out they have signals, and your ABI says, oh, ABI in one leg is 0.35, and the other leg is 0.34. They have no ulcers, no gangrene in the legs, but they've been walking like that for that pain for 3 months. You do the CT angiogram, like the doctor mentioned. Again, that person has what? Chronic ischemia. They may well be stable with that chronic ischemia. And I've had patients in the past where they have chronic ischemia, but they're able to function with it. And sometimes you go in and do something on the person who has been stable with low ABIs, they may get worse. So you have to kind of balance and see if your surgical intervention will make a difference. Okay, we did have an excellent case last night. We'll talk about later on also. Okay, so that was very good. Nice presentation on critical ischemia. We'll just have to talk about the rural setting and the more information on the hospital and interaction of the hospital and the physicians to make sure that works well. And additionally, again, in rural communities, again, especially when you have some hospitals in rural communities, it may be more prudent to maybe have the hospitals work together. So one hospital provides care, say for vascular cases. When the patient have vascular cases, they're directed at that. So not duplicating the resources. So if, say one hospital works on OB strong, the other hospital provides vascular surgery, the hospital provides the orthopedic surgery. So you don't have rural community hospitals and everybody trying to provide all the care. So it becomes difficult sometimes to expand. So again, that's a discussion for another day. So let's look into that. Okay, next presenter,
Current guidelines.
okay, will be student doctor Cristo Lamprakos. He is a veteran of the endovascular rotations here with me. He's back for a second session of that, and he knows what the drill is. So he'll be talking about current guidelines for PE. Thank you, Cristo.
Thank you, Dr. Oye. Thank you, everyone online, and thank you, students, for joining us. Okay. Today, we're going to be discussing the current guidelines of pulmonary embolism and DVT. I'm going to give you the newer guidelines that just came out, and I also want to help you be able to diagnose and kind of help you give an idea of what to do if you come across someone with a DVT or PE. Treatment for high-risk PE and massive sub-E. So this here is a ultrasound of the heart, right? You can see that this sign is called the D sign. So the D sign is created when excess pressure is put from the right ventricle onto the left ventricle. And the reason why I put this is because POCUS, which is point of care ultrasound, is now becoming the mainstay. So if you have a patient who is hemodynamically unstable and you're suspecting a PE, first thing you should do is kind of get an image. All right. If you can do image, if it's an emergency case, you want to start thrombolytic therapy right away, or you want to go straight for mechanical embolectomy. All right. So, and we're going to see other imaging as we continue. So acute management of PE. If you have high suspicions for a pulmonary embolism, you are going to do a bedside transesophageal echo. Okay, that's going to give you visualization. So right now you can see that there is a thrombus. Okay, there's a thrombus in the right artery here. Okay, now if you were to go a little bit more superior or inferior, you would see the ventricle as the D sign. But here we're looking for the thrombus. If you diagnose a pulmonary embolism, you are now going for CT pulmonary angiography. You want to visualize and see how large is the clot, where is the clot, and how can we manage. We do not delay treatment though. You want to start and support the patient immediately, right? We start oxygen therapy immediately. We can use BiPAP, and I want you guys to also, I'm not discouraging you. If the patient needs intubation, go for intubation, but avoid intubation if you can, because intubation can worsen hypotension. Okay, so once your patient's already going to be hypotensive, so we don't want to do that. Caution with aggressive fluids. Okay, you don't want to overload the right ventricle with fluids, and avoid medications that can also cause hypotension, like propofol and these things when you're going for intubation. Pressors can help. Norepinephrine has been shown to, help a little bit, but dobutamine is a little bit better. This is what the current guidelines are showing. So we're going to discuss quickly some medications. Venous thromboembolisms, they're clinically presenting as DVTs and PEs. It is the third most frequent cardiovascular symptom behind myocardial infarction, causing heart failure. Okay, so the first step is going to be anticoagulation. You want to prevent clot propagation. These medications do not dissolve the clot, they prevent more clot forming. Okay, so this is going to buy you some time. Okay, there's the direct oral anticoagulants. They are now preferred, easily administered, and we don't have to monitor them as often. Okay, like the low molecular weight heparin is good for patients with renal disease. Unfractionated heparin, also good, but it comes with high bleeding risk. Warfarin, I recommend you not to use warfarin unless you need to, because it needs heavy monitoring, and it's some patients it's going to get trouble. You don't want that. Here's a breakdown of how you want to administer the medications. Okay, so for the first 5 to 21 days, unfractionated heparin and low molecular weight heparin can be used. Rivaroxaban, the Zerlato, and Eliquis. Eliquis is a fantastic. We use it quite often in the office. And if you're going to be on extended use, you want to use the factor and the Eliquis or the Zerlato. They're much easier to manage, and you don't have to check as often. Long-term extended anticoagulation. And this is where you have to understand, is the patient having a provoked DVT? Was there surgery, immobilization, trauma? This anticoagulation usually is shorter. If for unprovoked, if we're not sure why this patient developed DVT, then we're going to go for more extended long-term anticoagulation use. And if there's cancer-associated thrombus, then we'll go for light molecular weight heparin. It's preferred over warfarin and the direct oral anticoagulants. So here I put some images of clots that were removed from the lung, and this was done through thrombectomy. This is the use of mechanical thrombectomy and PEs, and there are a lot of clinical trials that are providing evidence that show the safe and efficacy of mechanical thrombectomy. There was a trial here, and the study concluded that mechanical thrombectomy appears safer and effective in persons with intermediate risk. So you want to get the clot out to remove the strain on the right heart and make sure that perfusion is there. DVTs are treated with anticoagulation. In more severe cases, you can use mechanical embolectomy. And there's going to be a video later in this presentation that kind of shows you how that works. Now, in cases that you cannot use anticoagulation, it's absolutely contraindicated if a patient has had surgery within the last 3 weeks. If they are at a bleeding risk, you can use a IVC filter. IVC filter is basically kind of looks like umbrella, and it prevents the clot from moving up the inferior vena cava into the lung. Prevention. We want to prevent these clots from ever forming. Okay, a DVT is a potential PE. IVC filters are considered in these patients who have contraindications, as I mentioned. And routine use is not recommended. right? So we don't want to use these filters. Can be challenging to take them out. They have a little hook at the top, and then you can take them out endovascularly. Here's a quick case study. Let me play this quick video for you guys. So as you can see, this is a machine that we use endovascularly. It goes in to the artery and it actually dissolves the clot. We remove the clot and we suck it out, right? So this case was an 82-year-old African female presenting at the hospital with left thigh pain. She has a history of lymph node and mass resection due to cancer, which she had several years ago. Examination showed massive edema in the left lower extremity. Ultrasound and venogram confirmed an extensive iliofemoral popliteal DVT, and then we went in and removed it. So here is a video of the stenting. We put a stent in to kind of make sure that there would be no more block of flow. And here you can see the stent. All right. Thank you very much. These are the guidelines that have just come up, and thank you for this presentation.
Thank you, Cristo. Nice job. DVT and PE are usually very important topics to know in your clinical practice. You cannot go through your practice of medicine and surgery without finding a patient at some point that will present with DVT or PE. It's important that when you see a patient with DVT, especially for young patients, that your index for appropriate workup, it's very high. So you should be doing something very quickly. For young patients who present with DVT confirmed, provoked or unprovoked, and you see that they have the massive lower extremity edema, they have the pain associated with it. You want to be a little more aggressive. Dr. Chris is right. If you present and give you the DOAC meds and say, well, go in ER, go home, that may be helpful for some patients with small DVT load. If the DVT load is extensive, then their clinical symptoms may take a lot more time to resolve. So those are the patients that you have to be a little more aggressive. It may require thrombolytic therapy to remove a clot burden, sometimes mechanical thrombectomy to remove a clot. And we have a plethora of devices now that we can certainly use to improve flow in these patients and prevent the increased risk for PE. Sometimes we stent, sometimes we just do thrombolytic therapy, sometimes we do mechanical embolectomy only, and that's good enough, but it should be individualized. For that young patient clinically that presents with massive DVT and the treatment is suboptimal, they sometimes will develop post-phlebitic syndrome. So I have that massive swelling of that lower extremity for months or even years. And the downside of it is they have so much pain associated with it. If they usually work and they go back to work, they'll complain, my leg hurts, it's swollen, and then before you know it, somebody will be asking for disability options. So but on the other hand, if you treat them aggressively, you minimize that, you remove the clot burden, and therefore minimize or decrease the risk for the valvular damage that is associated with the blood clot being in the vein. Because when the clot sits in the vein, you just give an oral meds alone, it takes several months for recirculation to occur. So in that time span, you will damage the valves. And when the valves are damaged, the swelling becomes very difficult to control. So it's important. And when it comes to PE, like he rightly mentioned, we have different devices now for mechanical thrombectomy. Key here is to decrease the right ventricular strain associated with that. Again, when patients have silent embolism, you have to do something. You can't just leave them alone because they will die on you. And somebody that's young, it's unfortunate, things like that does happen. when we take long flights out, it's important that we evaluate ourselves if we're high risk for DVT, that we walk around the airplane, wear stockings, that will minimize problems with DVT. But that's a lot of people in some parts of the world. We know that once they have DVT or PE, the treatment options that we have available here in the United States are not readily available. So medical therapy alone is what they have, and sometimes that may not be enough when they have a significant involvement, and bad outcomes can be seen in those cases. So thank you again for that presentation. We would move on to our next talk if there are no questions. Any questions from the audience, please? Yes.
So like, I know it was mentioned like ultrasound kind of initially to check for that DVT. Is that more for like the proximal clots, or is it, can you also see distal like keys with the ultrasound?
Cristo?
The point of care ultrasound basically focuses on the right heart stream, and that's where you're going to see. To visualize the clot, you want to do more of a transesophageal, and then you can see the clot, and you can go a little bit lower. But once you have suspicion, you want to move for CT angio. That's just kind of to give you the confirmation where I'm like, yes, I have high suspicion. Then you'll move for CT angio.
Yeah.
It'll give you better visualization.
Okay.
And then you'll want to start as well treatment as well. You don't want to delay treatment.
Right, and then you still do that VQ if they can't tolerate contrast. Or
VQ more for pregnancy. I did not kind of
Or renal failure. If they have renal
Yes.
failure, you can give them
yes.
contrast. Yeah.
And my second question was regarding all the DOACs. I know there's a couple of them, and I've been in clinic before, and patients are really complaining of how much their Eliquis costs. So my question is, between like, you know, cost to benefit ratio wise, like, do you have any recommendations which DOAC is like? So I heard some things like Xarelto causes more bleeding than Eliquis, but I'm not sure. Like,
Yeah, I think it varies. Again, some of these companies, because of the cost associated with medicines, do present or give them some kind of cards to subsidize them. Again, when you look at treatment options, they present early in the course, and if you go in and you're aggressive, then your long-term need for anticoagulation is a lot less, than the cost associated with it will be a whole lot less.
My colleague here, Durav, he's done some research on cost-efficient.
So I recently just had the chance of looking at some of the pricing for medication here, and I found that oftentimes using an insurance for a patient or using a DOAC can actually increase the price of the medication in the pharmacy, at least here in our area. So oftentimes some patients will opt to not use their insurance and pay out of pocket. It'll be cheaper than their copay.
Sure. Yeah, it was interesting. I went once to a pharmacy to get some I believe it was Augmentin, and I got a price for something like $300
Oh.
for like 30 tablets. I'm like, whoa, that's expensive. You know, again, that's based on insurance, like you said. So yeah. So I think if we can identify the patients early on, we provide care in terms of aggressive therapy, then the need for the expensive therapies will be minimal, just maybe a month and a half, 2 months, and that way you don't have to stay on a lifelong anticoagulation. Again, there are some cases also where lifelong anticoagulation may be necessary. Those are patients that have a genetic predisposition. So you have the factor V, you have the Leiden factor V, you have anticoagulation levels, and protein C, protein S. Those patients may need lifelong anticoagulation. So fixing the appropriate one helps. Again, Coumadin sometimes can be the best choice in terms of cost. It's been around for a long time. Managing those patients who can afford this expensive other options, it's there. So we can also be careful when we use it. Yeah, very good. Any further questions? Any questions from, yeah, you got one more question? Yeah.
Sorry about that. I
No,
have
no.
another question.
Yeah.
I know that there's an ongoing controversy with regards to the current ACLS guidelines and resuscitation in the ER.
Yes.
For possible cardiovascular compromise. And I know Dr. Lamprakos was talking about this the other day with me in the hospital. He mentioned something about using something about the addition of an ultrasound at the bedside in the ACLS guidelines?
Yeah, ACLS is now currently updating its guidelines. It wants to use POCUS, which is point of care ultrasound. You can use the ultrasound to evaluate the heart as well as the inferior vena cava to see kind of what's going on, especially if you're during a code, if your patient has no heart rate or you have, there's no rhythm, quickly figure out, is there PE, is there strain, maybe their fluid is down. You know what I mean? It's important to be able to quickly visualize what's going inside. So this is something that's being incorporated into the guidelines currently.
So what point would they add that on? Would it be?
As soon as possible. You'd get a rhythm strip, see if you have a rhythm. If not, immediately do a quick ultrasound. It takes only a couple seconds. You can do an ultrasound in about 10 seconds.
So kind of around the time that they would change and take pulse?
Right. Yeah.
Well, it makes sense when you evaluate the patient. The patient comes in unresponsive, for example, in the patient, you think it's a case of shock or fluid depletion. And if you think they're bleeding, and a quick ultrasound can tell you if there's fluid in the abdomen. So that makes sense. That's something we've done for years. Again, the use of ultrasound, because of its ease of use, because of the decreased radiation concerns, all those are plus. Plus is that one could add, and obviously you don't want to be using ultrasound when you need to be, doing compressions. You have to start the compressions, do all the things you have to do, but again, maybe concurrently do that while you're sort of as a team member. So hopefully it will incorporate that in a nice way. The other option, I think that I need to mention when it comes to PE and DVT is a PERT, PRT, the Pulmonary Embolism Response Team. Just like we have the MET team, just like we have the Stroke Alert. There's now a big push because of the bad effects associated with PE. Therefore, the PERT team. So the PERT team will consist of the pulmonologist, the vascular surgeon, the nurses, the respiratory therapists. So the patient has all the options to potentially make them survive that event. Again, decrease the heart rate.
There's one question online.
Yeah, question from online. Yes. Yeah, Dr. Shangre, please go ahead.
Yeah, I've been raising my hand.
Oh, sorry about that.
for a while. That's okay. Let me lower my hand. Well, a couple of comments. In trauma, one of the things we do to prevent this thromboembolism is the low molecular weight heparin. In the olden day, we used to just do 40 milligram Lovinox once a day in patients with major trauma. But now we've realized that we should be doing it twice a day. There was a little bit of pushback from the orthopedic, thinking that if there is also a fractured hip or fractured leg, and we are giving such a high dose Lovinox, that will increase bleeding. We've instituted it twice daily Lovinox in Raleigh General. We haven't seen any concern with increased bleeding. So these are the things that we're looking critically to make sure we don't develop PE or DVT with this multi-system trauma patient. Older surgeons like me were a little bit reluctant to go to twice a day Lovinox, but slowly we are getting into that, because just like everybody knows that prevention is a lot better than this aggressive treatment. So that's my comment. The second question is there any role for aspirin at all in the long-term treatment or prevention of DVT or treatment of DVT, like in the developing country where the cost of all this medication that you are mentioning are very high? We know aspirin is available and not a lot cheaper than all this new medication. What is the role of aspirin? Does it have a role at all? Thank you.
If the patients have concurrent arterial and venous disease, aspirin is usually part of the regimen. My patients in vascular surgery, we usually have a significant arterial disease. They're usually on aspirin unless they have allergy to aspirin. Even if they're taking the Coumadins or the Eliquis and the others, they always don't have aspirin still. So that's the role for it. The key here would be in developing countries or underprivileged societies that don't have the luxuries of this medicines due to the cost. I guess careful use of warfarin can still be a useful option. Again, taking care of the necessary other side effects that may occur, the bleeding, yes, but avoiding certain foods to make the medication more optimal should be considered. But again, if the society or the hospital or the community is blessed to have invasive technologies where the clot can be removed, then that would make sense. Aspirin therapy alone may be reasonable because the clot's no longer there, or short term of the anticoagulation rather than the long term deal. So thank you for your comments, Dr. Shangan. I appreciate it. Yeah, any further questions before more next topic? Yeah, okay. So thank you so much. We have two good presentations so far. Our next presenter is student Dr. Disha Shah. She'll be talking to us on an exciting topic, interesting case study, and we look forward to her presentation.
This one. This one?
Yeah. Is there any way to
This one. Leave it.
minimize the green?
If you want to see your camera, you can click the one right next to the minimize.
Just that?
Yeah, that small one. Yeah, that way you can see your camera.
I don't think that's,
Yeah.
it's okay. It's fine.
Show it one. Yeah.
This one?
Yeah, that whole tab will show up on.
Yeah, that's just for you to.
That's just our screen.
Yeah, you can put that on. That way you can see, what's going on there. So tap that so we can see who's on. Yeah, okay.
I texted Tammy about the thing. How do I make this just the slideshow? Bottom? This one? What is, no, like, okay. It looks like that. All right. Good morning, everybody. My name is Disha Shah. Thank you to everybody for coming. Thank you to everybody for presenting. And thank you, Dr. Oye and Cristo, for holding this. Today I'll be talking about peripheral vascular disease resulting in surgical intervention. I'm going to go through briefly about a little bit about PAD, and then I'll talk about our case afterwards. So the objectives today for you guys is to learn about peripheral artery disease, review the anatomy of the iliac and femoral popliteal arteries, understand the indications for angioplasty and stenting, outline procedural steps for both right iliac and left femoral popliteal interventions, identify potential complications and management strategies, and then we'll discuss our patient's case. So what is PAD? PAD is a condition that is characterized by the atherosclerotic narrowing of peripheral arteries, most commonly of the lower extremities. So lower extremity PAD may be silent or present with a variety of symptoms and signs indicative of extremity ischemia. The clinical manifestations of arterial insufficiency, regardless of etiology, are due to a lack of blood flow to the musculature relative to its metabolism, which results in pain in the affected muscle groups. Ankle brachial index and or Doppler ultrasound can be used in the outpatient setting or at bedside to detect narrowing of the arteries, or as screening measures in those who are asymptomatic with risk factors and or comorbidities. Also CTA, MRA, and DSA, which I'll talk about in a little bit, can also be used depending on specific indications like timing, severity, complications, and risk factors. Traditional angiogram is typically used during revascularization to gain access to real-time imaging of stenosed vessels and guidance in successfully restoring blood flow. To the right, you guys can see these images. They're just images showing normal artery and atherosclerotic arteries. So now let's talk about, I know everyone kind of knows the gist of the pathophysio, but we'll just go through it again just to recap. So step 1 is due to endothelial dysfunction. So this is damage to the endothelium that can be triggered by factors such as smoking, hypertension, high cholesterol, diabetes, and inflammation. When the endothelium is damaged, it becomes more permeable to lipoproteins. Step 2 is lipid accumulation. So once lipoproteins enter the arterial wall, they undergo oxidation, making them more likely to trigger an immune response. And then macrophages then ingest the oxidized lipoprotein and become foam cells, leading to the formation of fatty streaks in the arterial walls. Step 3, over time, those fatty streaks develop into atherosclerotic plaques consisting of lipids, immune cells, smooth muscle cells, and connective tissue. The growing plaque narrows the artery's lumen and restricts blood flow. The plaque may have a fibrous cap on its surface, which stabilizes it, but also puts it at risk for rupturing. If the fibrous cap becomes unstable or rupture, it can expose the underlying lipid-rich core to the bloodstream, and this can trigger formation of a thrombus at the site of rupture. The thrombus can completely block the artery, leading to sudden severe reduction in blood flow, and if left untreated, can result in acute limb ischemia, which may lead to tissue necrosis and possibly amputation. So now let's talk about some of the stats. So the prevalence of PAD increases progressively with age, beginning after age 50. The global prevalence is estimated that 200 million people worldwide are affected by PAD. US prevalence, approximately 8 to 12 million people of the US have PAD. PAD affects 5 to 10% of people aged 50 to 65 and 20 to 25% of people over the age of 80. Gender differences. So PAD affects men and women almost equally, but women tend to be diagnosed later and may have worse symptoms. As for ethnicity, in the US, African Americans are approximately twice as likely to get PAD, twice as likely to develop PAD compared to Caucasians. And then as for the economic impact, the annual healthcare cost attributed to PAD in the US is estimated to be 21 billion, and hospitalization for PAD-related complications like critical limb ischemia or amputations can cost anywhere from 25,000 to 60,000 per event. So signs and symptoms. Those that are symptomatic will experience lower extremity pain at rest, intermittent claudication of the buttocks, the hip, the calf, the thigh, or even the foot. They can also have skin temperature and color changes, skin discoloration, or gangrene. The gangrene comes with, it's more so related to the critical limb ischemia. Weak or absent pulses, non-healing wound, or ulcer. And if they're asymptomatic, then obviously there's no signs, but they should be screened, and that should be done after the age of 40 for those with risk factors. And that's initially done with ABI or Doppler, can be done at bedside or in the office. So risk factors. The 3 biggest ones are smoking, hypertension, diabetes. And then we have older age, certain ethnicities, like we talked about, known atherosclerosis at other sites, family history of atherosclerosis, and hyperlipidemia. So treatment and prevention. So the non-surgical portion is kind of the treatment and prevention part, and then the surgical portion is more so the treatment part. So as for non-surgical, we have lifestyle changes. So smoking cessation, glycemic control if you're diabetic, regular exercise if you're a sedentary person. And then we have medications such as aspirin, clopidogrel, statins to reduce the risk of heart attacks and strokes that are associated with PAD. And then we have supervised exercise therapy, such as structured walking programs to improve signs and symptoms of claudication. As for surgical, we start off with endovascular procedures like angioplasty and stenting, which is our main topic today. And then we can do bypass surgery, which is when we have a vein or a synthetic graft that's used to bypass blocked arteries and restore blood flow to the affected limb. And then lastly, we really don't want to do this because we're trying to preserve everybody's limbs, but we could also do amputation if the blood flow cannot be restored and there is tissue death. Okay, so now let's talk a little bit about the anatomy. So this is the anatomy of the iliac and femoral popliteal arteries. The iliac arteries arise from the aortic bifurcation and supply the pelvis and the lower limbs. They're divided into common internal and external iliac arteries. And then the right iliac artery branches to provide blood to the right leg and vice versa for the left leg. The femoral artery is a continuation of the external iliac artery and runs down the thigh. It becomes the popliteal artery as it passes through the popliteal fossa. And these arteries are key to supplying blood to the lower leg and the foot. And you guys can see where all the arteries are in the images. Okay, so a little bit about the diagnostic workup. So first we'll start off with Doppler ultrasound. Doppler ultrasound can help evaluate the degree of stenosis by assessing blood flow and detecting turbulent flow patterns that suggest any narrowing. The advantage of this is that it can be used for screening purposes, like I had mentioned earlier. It's non-invasive, no radiation or contrast required, and it's widely available and cost-effective. Some limitations are that it may be less accurate for deeper vessels, such as the iliac arteries, and it does not provide direct visualization of the vessel narrowing. And that's a picture of what it would look like. Okay, so the next one is ankle brachial index. This is a simple non-invasive test used to assess PAD by comparing blood pressure in the ankle with the blood pressure in the arm. So an ABI of less than or equal to 0.9 has a high degree of sensitivity and specificity for a diagnosis of PAD. And it helps detect blockages or narrowing in the arteries of the legs. So some advantages of this, again, is that it can be used for screening purposes at bedside or in the clinic. It's non-invasive, quick and simple, early detection, helps with early detection of PAD. It's cost-effective. Some limitations are that it's limited to lower extremity arteries. It's less accurate in certain populations. We cannot identify location or severity of blockages, and it may not detect mild PAD. And then it's also limited therapeutic guidance compared to angiogram. So now we'll talk about catheter angiogram, also known as traditional or conventional angiogram. It's an invasive procedure that involves using a catheter that is inserted into our artery, usually through the groin or arm, and is guided into the affected area. Angiograms use continuous X-rays, which is fluoroscopy, to visualize the blood vessels after the injection of contrast dye directly into the arteries. Some advantages for this is that it shows real-time imaging and diagnosis, immediate treatment, so it has therapeutic capability, and then high-resolution imaging compared to CTA or MRA. Some limitations are that it's invasive, risk of complications such as blood clots, stroke, or heart attacks, and we have radiation exposure, and we also have the use of contrast dye. So in those with CKD or those with allergic reactions to the dye, it's not preferred, but we can still use it. Okay, and then we have CT angiography. So CTA provides a highly detailed cross-sectional image of the arteries, including the extent and severity of any narrowing or blockages. So you get a better anatomical visualization. Some advantages are that you have high spatial resolution and accuracy, rapid acquisition of images, and it provides 3D reconstructions of the blood vessels. Some limitations, again, is that it requires contrast injection, so it may be problematic for those with CKD, and it also involves radiation exposure. And then we have an alternative to CTA, which is magnetic resonance angiography, which is MRA. MRA doesn't involve any radiation and can be used with or without contrast. It offers excellent visualization of deeper arteries and is preferred in patients with CKD who cannot tolerate the iodine-based contrast. Some advantages are obviously, again, the no ionizing radiation, and then it provides detailed images of both blood flow and vessel anatomy. Some disadvantages is that it's got longer scanning times compared to the CTA, and it's not widely available. And it may not be suitable for those who have pacemakers and metallic implants. So lastly, in the diagnostic workup, we're going to talk about DSA, which is invasive digital subtraction angiography. DSA is considered gold standard for the definitive diagnosis of arterial stenosis, including deeper vessels such as the iliac arteries. It provides real-time high-resolution images and allows for both diagnostic and therapeutic interventions like balloon angioplasty and/or stent placement. Advantages for this is that it provides the most detailed and accurate images, allows for immediate intervention if necessary. Disadvantages are that it's invasive, involves contrast dye and radiation, and has a small risk of complications like bleeding, infection, and arterial damage. So now we're going to talk about indications and preparation for angioplasty and stenting. It's just a little review of how we do it. And I did this because this is my first rotation on vascular surgery. So I kind of needed to read up on it, and I didn't know if everybody knew kind of just the basics of it. So I figured I'd put it in here. So indications, when would we do it? When there's severe stenosis, so greater than 70%, causing claudication or limb-threatening ischemia, or failed conservative treatments such as exercise or pharmacotherapy, or multi-level arterial disease or long segment lesions. So the equipment needed for angioplasty and stenting, again, this is just the basics of what we would need. So we'd need guide wire, balloon catheters and stents, access sheets and fluoroscopy, fluoroscopic imaging equipment, and angiographic contrast and hemostasis devices. So the steps for angioplasty and stenting, again, just a little basic step by step. So step one, we would access is usually achieved via the femoral artery for iliac and fempop interventions. Ultrasound guided puncture can improve accuracy and reduce complications rather than just going blindsided. Step two, the guide wire is advanced past the lesion under fluoroscopic guidance. Ensuring proper wire placement is critical for advancing the necessary catheters. And then step three, a balloon catheter is positioned at the site of stenosis and inflated to dilate the artery. This increases the vessel's diameter and improves blood flow. And then step four, a stent is deployed to maintain the artery's patency. Post-dilation may be required to ensure optimal stent placement and vessel remodeling. So this is the right iliac angioplasty overview. So right iliac lesions often require balloon expandable stents due to their larger diameter. Stent placement must ensure optimal proximal and distal landing zones. Some key considerations to keep in mind is to pay attention to the potential for iliac artery recoil and careful post-deployment angiography to confirm the stent position and vessel patency. And then again, on the left, you guys can see the arteries. So this is the overview for the left femoral popliteal angioplasty. The femoral popliteal region is prone to long segment stenosis and occlusions. Self-expanding stents are often used due to the flexibility required in this region. Popliteal arteries are mobile and subject to compression and flexion. Choosing stents can accommodate the artery's movement is very crucial. And like I said, again, you guys can see the arteries right here on the right. So some complications of angioplasty and stenting. Common complications include vessel dissection, stent migration, and restenosis. It's rare but serious. You can get embolization, perforation, or acute thrombosis, and use intraoperative angiography to assess for complications early is also very, very important. Post-op imaging and care. So we want to do post-stenting angiography to confirm the adequacy of the procedure. Follow-up imaging may include Doppler ultrasound, CTA, or MRA to assess for any sort of restenosis. Routine surveillance is crucial in high-risk patients because it can become, again, restenosed and then become critical limb ischemia. Antiplatelet therapy is essential to prevent stent thrombosis, so aspirin and clopidogrel, and then monitor for signs of limb ischemia or bleeding at the access site and encourage early mobilization to reduce the risk of complications. And long-term follow-up and surveillance. Regular follow-up to monitor stent patency is important, especially in those that are high risk. Use Doppler ultrasound or CTA to identify restenosis early, and lifestyle modifications and medical management of atherosclerosis is crucial. Re-intervention strategies. So restenosis may require repeat angioplasty, stenting, or even bypass surgery. We can use drug-eluting stents and covered stents for the management of restenosis. And then endovascular intervention is preferred over surgery for most cases because it's less invasive. And that's the goal. All right, so now we'll talk about our patient. Our patient, she had a bilateral iliac angioplasty with stent placement and left fempop angioplasty with statement. So our patient is a 76-year-old woman. She presented with a 2-month history of varicositis, bilateral leg pain, feet that were cool to touch, and bilateral purple discoloration in the feet, the left being greater than the right. The patient was ambulating with a cane. Social history includes that she was a former smoker. Past medical history includes COPD, history of PEs, hypertension, hyperlipidemia, peripheral artery disease, hypothyroidism, osteoporosis, and compression fracture of spine. So you guys can see that she obviously had a lot of risk factors. And her CT angiography demonstrated significant left superficial femoral and popliteal artery stenosis, proximal aortic stenosis, and right common iliac stenosis. So let's talk about the surgery that we did. So the aortogram and iliac arteriogram. The procedure began with an aortogram and bilateral iliac arteriogram to evaluate the condition of the patient's arteries, specifically identifying areas of stenosis. And then pre-procedure findings Imaging revealed significant stenosis in both iliac arteries, along with a blockage of 80 to 90% in both, contributing to the patient's symptoms. And the patient actually had a previous stent that was distal to the renal arteries. And then we saw, when we did our own imaging, the CT was actually done in Charleston, West Virginia. But when we did our own imaging, we saw that there was 80 to 90% stenosis above that previous stent. And so a new stent was placed proximal to the old stent. So as for the stent deployment, we did two 10 mm by 40 mm fluency plus stents that were deployed in the iliac arteries to open and maintain the blood flow through the narrowed artery, covered stents. And then as for the balloon angioplasty, we did the kissing balloons. So we did 10 by 40 and 8 by 40. And those were used to further dilate the iliac arteries to ensure proper blood flow. And then an additional balloon angioplasty, 5 by 100 Mustang balloon, was performed on the left femoral popliteal artery to treat the stenosis in that region, which was 70%. And then the stents expanded successfully, with the patient achieving improved arterial flow through the treated vessels. And then Doppler imaging confirmed adequate blood flow. There weren't any complications after the procedure. And the distal pulses, the DP and PT were intact post-surgery. Sutures and compression dressings were applied, with the patient tolerating the procedure well. So here are some images from her surgery, her initial surgery. So in figure 1, which is the one on the left, the top left, this is pre-angioplasty with visible stenosis. Blue lines demonstrate the area of blockage. Figure 2 is balloon angioplasty in progress. The balloon is being inflated to widen the narrowed section of the artery. And again, the blue lines indicate the initial area of stenosis. And then the figure on the bottom is figure 3. This image shows a stent being positioned to keep the artery patent after the angioplasty.
So figure 2, you can see the pre-existing stent. And then above that, like you mentioned before, was hydrostenous 80 to 90%. You can see the narrowed area. It's right below the renal artery. So if you leave that alone unattended, then you fix the left fem-pop segment alone, she's going to have an inflow problem still. Or if that gets completely occluded and you cannot reopen it, then your patient will be subjected to a major bypass operation, or in that direct remove the plaque and stent. So we elected to put the second stent to overlap the old stent in the level of the renal artery. So if you look closely on the third picture, you can see the second stent now right below the renal artery, and now it's fully engaged. The difficulty we also had in this case was once we deployed the first stent in this case, especially had pre-existing stent, the stent that's below the renal artery going down, the top portion of the stent fled up, and the bottom portion of the stent would not. So we had to deliver at that point. It's critical when you do this procedures that you maintain the wire access. So because the wire was still within 2 stents, we rather than use a large balloon to go through that narrow area, if we've done that, there's a good chance we'll push the stent. This is a covered stent. We'll push the stent, and the stent may now include renal artery. So we picked or selected a smaller stent that we could easily pass through the wire to the lower portion of that stent that wasn't deployed, and we inflated that a little bit. Then we'll put a larger balloon to now expand it further. So as you can see, the acquisition now looks excellent on figure 3. So that was a pretty cool case. Again, key is maintain the wire access, which is great. Go ahead.
And so here in figure 4, this is post-stent placement with balloon inflation. The image shows the balloon being used again to expand the stent fully within the artery. And then in figure 5, this is the arterial flow post-intervention with stents visible. The flow has been improved and stents are in place, maintaining the arterial lumen. And then here's a little video that we took. This is the final angiogram showing restored blood flow, post-angioplasty and stent placement. The artery appears patent with no significant blockages.
Okay.
And so here's the fempop part. Figure 7, which is the top left. This is pre-fempop angioplasty with visible stenosis. Then the one next to it is angioplasty in progress with stent placement with revascularization of the left fempop. And
Stent placement.
yeah, with that. And then the bottom one is the final angiogram showing restored blood flow with post-angioplasty and stent placement. The artery appears more patent with robust blood flow.
Without stent placement.
Yes, sorry, without.
In our experience, we know that in the fempop segment, patients do develop thrombosis sometimes, in my experience of putting stents in the fempop segment, I kind of shy away from it and only use that as a last resort. If there's a dissection or an area where, in spite of prior balloon angioplasty, you're not getting the desired results, then maybe stent may be considered. And also nowadays, we have the great option of using intravascular lithotripsy, which can fracture the plaque and also prevent us from putting stents in some patients.
Okay, so post-surgery complications. This is specifically what happened in this patient's case. So the 76-year-old woman, she developed a left femoral pseudoaneurysm, a left groin hematoma. She had continuous bleeding from the abdominal wall, and she had continued right femoral stenosis due to improper movement of the stent towards the left side. So pretty much the stent that was on the right side was moving towards the left. So we ended up doing a
Stent on the left side was moving towards the right. Stent was
on the left side.
Side was moving towards the right. Yeah.
Okay. So we ended up doing the revision surgery. We ended up doing 2 revision surgeries. The first one was for the pseudoaneurysm and for the hematoma. So the pseudoaneurysm was confirmed in the left groin following CT angiography. Right common femoral artery was cannulated using real-time ultrasound guidance, and a right iliac stent was placed to address stenosis. A kissing fashion stent technique was used to deploy a 9x40 fluency plus stent. Balloon angioplasty with the 10x40 conquest balloon resolved the stenosis. Entry site in the right iliac was approximated with sutures and compression applied for about 30 minutes. Pseudoaneurysm in the left groin was treated by excising the graft hole and applying a ham-shelled patch after irrigation. And the surgical site was closed with a combination of sutures and staples with no complications encountered, and the patient tolerated the procedure just fine. So on the left is the pseudoaneurysm and hematoma. And then on the right is the unrepaired iliac stenting, and then on the last picture is the repaired iliac stenting. And then this was revision surgery number 2. The patient had some recurrent bleeding from the left groin after the previous pseudoaneurysm repair, but the aneurysm appeared intact. The abnormal bleeding came from the intramuscular sources. Her hemoglobin levels were down to 12, but nothing too crazy. And the area was re-explored to ensure no active bleeding from the repair of the abdominal wall. Electrocautery was used to control bleeding, and the muscle tissue was approximated using 0 vicryl sutures. And then Jackson Pratt drains were inserted and the skin was closed with 3 to 0 Prolene sutures and staples with no further complications. The patient was transferred to ICU and intubated, and she's stable. We just saw her day before yesterday. She's looking a lot better as well.
And extubate.
Yes. Oh, she got extubated?
Extubate
Okay.
and talking with phone.
Okay, good, good. She was still intubated when we saw her, but she's extubated, doing good. So the biggest take home point was that during the first and initial surgery, the bigger balloon was deployed, like Dr. Oye had said, and that was an attempt to place the new stent proximal to the previous stent. So while doing this, we had to switch to the smaller balloon in any fear of dislodging the old stent into the renal arteries. And that's it. Thank you.
Any questions, please?
So this kind of goes back to his presentation on like the basal trial, like stent versus bypass. And I believe in that presentation, there was some mention on like, you know, not really any difference, right, in the basal trial. So like, yeah, I was just wondering like what outcomes, like if you know, like were covered in that basal trial, and what outcomes, if there are any, like would there be like different between like a bypass and a stent?
Well, in this particular case, we do know that plain balloon angioplasty and stenting of the aorta and the iliac arteries has been found over the past 30 years or so to be equivalent in terms of long-term patency. If you do angioplasty and stenting of the aorta and iliac arteries, you have about 90% patency rate in 5 years. Now, if you do a bypass, it's about the same. We know bypasses stay more durable in terms of long-term regenerative peripheral bypass. If the person doesn't smoke or lives a lifestyle modifying factors, they can have that bypass paid for 15, 20 years. But ordinarily, in 5 years, stenting of the iliac arteries and bypass should be similar or equivalent. So in that case, the key concern in this particular case was here was an elderly lady with significant left lower extremity ischemia. Now she had a CT angiogram that was done at an external institution, which only mentioned there was an aortic prosthesis, didn't mention that there was a stenosis in the aorta above the prosthesis stent that she had before. And that's the value of doing intraoperative, that's the value of doing intraoperative arteriogram, to on-table arteriogram to see what you have or don't have. So by placing a catheter in the aorta at the suprarenal location, and then going ahead and doing the intervention, the arteriogram, we're able to identify not only does she have a stent there, but she had the narrowing or blockage of 80 to 90% above that stent and directly below the renal artery. So if you leave that unattended and you just go ahead and treat the left fempop or the iliac, she'll come back with a major problem because that's an inflow problem. The problem is not going to be solved. So obviously, at the time of surgery, you have to modify your thinking, and that's the beauty of vascular surgery. You go on one plan, and at the time of surgery, things do change. And then you have to be able to be flexible enough to do what it takes to get a better or best result. So that was the case here. One of the things that we also have to mention, when we use covered stents, the platform that we use, the sheet's a lot larger. The particular brand, 9 French, 10 French. That's a big sheet going through an artery. Again, we're doing this percutaneously without any cuts. So we typically, most times, don't have a problem with holding pressure, but sometimes they have a problem. If you go back and look at this particular lady, we use a 10 French sheet, which is larger on the right groin, and only a 9 French sheet on the left groin. But so the aneurysm developed on the left groin. Then after we opened on the second surgery, again, remember, with endovascular intervention, you have 2% complication rate. This is that 2% we're talking about. So once we got in, we opened the pseudoaneurysm, we could see the hole where the artery entry side was still pumping. So we put some stitches and pledgets and control that. So that took care of that. The other option was at the time of the initial surgery, my assistant for the case, that's why I talk about wire integrity, maintaining wire integrity. I was in the midst of deploying the stent, and when I looked around, the wire was gone. So it made the proximal stent on the left side deployed a little higher into the distal aorta. So it was compromising the flow to the right common iliac entry site. It didn't look too bad on the original surgery. I'm like, well, let's leave it alone. Don't put another stent. In retrospect, we should have done that. So when she came back, first thing we did again was go back, put a catheter up there to make sure the aortic stents were patent. They were. Then we brought the catheter down to this infrarenal aorta or suprailiac area. Then we did a teargram move, then confirmed again the stent on the left was encroaching towards the right some more instead, because the repeat CT angiogram that's give it about 7% stenosis. So we knew we had to stent that, put additional stent to kind of make them equal. So we then used another 9 French sheath again this time, unfortunately, still percutaneously. We're able to stick that and then put another stent so match the one on the left. So they're both in the aorta itself equally. So when you deployed it, then it's a lot more secure. Then we obviously fixed the pseudoaneurysm. So it worked out well for the patient. But then she had this bleeding recovery, and it didn't make any sense. We knew we didn't do anything else, but she was bleeding. So we had to on the left side. So we had to go back and took care of that. It looked nice and dry. She goes back to the recovery room and she oozes again. So at 11 o'clock at night again, I had to go back and see what the heck is going on. And this time we found that she had abdominal wall oozing that was just more significant when we did a few things, and that solved the problem. So it was an interesting case, all in all. Yeah, very good. Again, would like to take this opportunity to thank our partners in this process, the Uzuma Foundation for publicizing this event and also having members join us. We also would like to thank the Oya Global Medical Foundation and the ISES, International Society of Endovascular Specialists, and the endovascular as well as the Bielsa Special Hospital partner in Africa. So anyway, our next speaker will be ready to change gears. By the way, Dr. Shah did a fantastic job of giving us a broad overview of PAD. So I take it now, everybody in the forum, physician, non-physicians, now know about PAD, and you can now diagnose PAD in yourself or your families. Thank you so much. Our next speaker will be Prerana Upadhya, and she would be talking to us on chronic lymphedema due to subclavian vein stenosis. So we're shifting gears now towards the vein system instead of the arterial system. Doctor.
All right. Okay. Good morning, everyone. My name is Prerana Upadhya. I'm a third-year medical student here with Avalon University, doing my co-rotation with Dr. Oye. And today I'm going to be talking about chronic lymphedema due to subclavian vein stenosis. So let's start with the case vignette. We have a 75-year-old male with past medical history of end-stage renal disease and CKD requiring long-term hemodialysis. Physical examination reveals swelling of right upper extremity and right breast, acute embolism and thrombosis of deep veins of right upper extremity noted on Doppler. Surgical history includes port and AV fistula in the left upper extremity. Patient is currently placed on the transplant list.
Actually, I had transplant.
He had a transplant, okay. So here I have the ultrasound image, and we can see these islands of edema in his right breast and his right upper extremity. So our diagnosis here is right subclavian vein stenosis, which was about 75 to 85%. And I've included this diagram to show a little bit of anatomy for us to better understand the procedure. So we have the basilic vein and the brachial vein, which goes and joins with the cephalic vein. Well, they join and become the axillary vein, and then they join with the cephalic vein and drain into the subclavian vein. So starting with the operative report, we did a right forearm AV fistula with basilic vein cannulation under ultrasound guidance. And then we did a venogram of the right upper extremity and the venogram of the right subclavian vein stenosis. And we did a angioplasty of the right subclavian vein with stenting. So to go into the procedure a little bit more, we started with cannulating the vein with the help of a microvenous needle at the forearm area. Microvenous wire and sheath were introduced, and venogram was then performed to demonstrate flow to the basilic vein into the subclavian vein. Venogram was performed using a low osmolality contrast. No evidence of stenosis was found on the superior portion of right subclavian vein, but more proximally with cannulation to the distal vein was done. Below the axillary area, we found 2 areas of stenosis, and for that we used a 4 French sheet, and then we upsized to 6 and then upgraded to 10 French sheet. So here on the venogram, we can see two significant area of stenosis. And then we went with the glide wire. Advantage wire was then passed across the lesion, and stenosis was confirmed at the subclavian area. We noted 2 areas of stenosis, and then we performed an angioplasty using 12 by 40 non-compliant balloon, followed by a 13.5 by 4 centimeter fluency covered stent in the most proximal and significant stenosed area. And then we went in with the second 14 by 60 non-covered stent for the entire area. And then we had to use another 12 by 4 and a 14 by 4 non-covered stent to treat the lower portion of stenosis to improve the apposition and convexity. So here you can see the first one. Then we used a post balloon angioplasty with 16 by 40 millimeter balloon, and we were able to achieve excellent apposition to the wall, and we noted good flow. And then we used the sheet wire, and the sheath and the wire were removed, and we used 5-0 Prolene sutures, and we applied compression dressing as well. So here, that's the post angioplasty balloon, and we can see a pretty good flow compared to previous flow. And yeah. Now, etiology of subclavian vein, just an overview. It could be extrinsic or intrinsic. Extrinsic would include compression of the left brachiocephalic vein between the sternum and arch vessel, which is part of the thoracic outlet syndrome. And we can have some regional tumors such as lymphadenopathy or mediastinal inflammatory pseudotumors. And it could also be intrinsic, which is associated with stenosis associated with previous IV lines, such as hemodialysis catheter, which we saw in our patient. He has extensive history of long-term hemodialysis, and it could be hemodialysis-related subclavian vein stenosis, thought to be from intimal hyperplasia secondary to increased turbulent flow from created AV fistula. So now I'll be talking about lymphedema so that we have a better understanding how to diagnose it and how to treat it. So lymphedema refers to tissue swelling caused by an accumulation of protein-rich fluid that's usually drained through the body's lymphatic system. It most commonly affects the arms and legs, but it can also occur in other areas of our body as well. At birth, 1 in 6,000 will develop lymphedema with an overall prevalence of 0.13 to 2%. We have two types of lymphedema, primary and secondary. Primary it's pretty rare. It would be about 1 in 100,000, and secondary would be 1 in 1,000. So secondary is pretty common, and that's just the Americans. Now, primary has 3 subtypes: congenital, precox, and tarda. Congenital is if it occurs before 1 year of age or 2 year of age, and precox would be anywhere from 1 to 35, and tarda is after 35 years of age. So primary basically, I would say it's something to do with the lymphatic system. So it could be agenesis, it could be dysgenesis, it could be atrophy of the lymphatic system, something that's wrong with the lymphatic system itself. And then secondary would be, it could be lymphatic obstruction, it could be interruption, but most commonly we see secondary type with after breast cancer surgeries like radiation or, okay. Going more into the etiology, the most common cause not in developed countries, sorry, it's developing countries, would be filariasis, which is also known as elephantiasis. It's caused by a parasite called Wuchereria bancrofti, and this parasite basically goes and sits into your lymphatic system, and that blocks the lymphatic system. So that will cause the any limb to look like this. And we can also have malignancy, such as breast cancer is the most common cancer associated with secondary lymphedema. Then we can have any type of local radiation therapy, peripheral vascular surgery, DVT, or any oncological surgical procedure, which is sentinel lymph node biopsy. And signs and symptoms of lymphedema include swelling of part or all of the arm or leg, including fingers or toes, feeling of heaviness or tightness, restricted range of motion, recurring infections, hardening and thickening of skin, which is fibrosis, skin changes such as hyperkeratosis, lichenification, lymphuria, which is when the lymph fluid leaks from the skin because of so much pressure and the skin is not able to hold all that pressure. So it eventually breaks and leaks. And we can also see ulceration, but it's kind of really rare and unusual. Now, for the risk factors, they include extent of local surgery, anatomical location of lymph node dissection, radiation to lymph node, localized infection or delayed wound healing, tumor causing lymphatic obstruction, intrapelvic or intra-abdominal tumors that directly compress the cisterna chyli or thoracic duct, having a higher disease stage, overweight or obese, which is more than 30 BMI, and Black race and Hispanic ethnicity. So we use a Brunner classification to stage the type of lymphedema. We start with stage 0. There's no swelling with changes found in imaging only. Then we have type 1, which will show a classic sign of pitting edema, which is because of the fluid. Second stage would be solid predominance, so we'll see non-pitting edema. And the third one would be late stage with superficial skin thickening, significant disfigurement of the limbs, and so on. For differential, we can confuse these things with lymphedema, starting with venous causes. It could be DVT, such as in our case study today that I talked about, and it could be arterial, such as AV malformations or aneurysms. And then non-lymphatic, non-vascular causes include CHF, glomerulonephritis, allergy, drugs, obesity, cirrhosis, cellulitis, Baker's cyst, pretibial myxedema, seen in hypothyroidism. Can be confused with lymphedema. To investigate lymphedema, we'll first start with routine blood tests such as CBC or any urine analysis and all that stuff, and then we'll move on to imaging tests. The gold standard here is lymphoscintigraphy, which includes injecting a radioactive dye into the lymphatic system to track the movement of lymphatic system throughout the body. We can also do a CT scan, MRI scan, or ultrasound. So here I've included a picture of lymphoscintigraphy. The black dots you see is where they inject the radio dye. That's why it looks like that. It's in the first web space of our feet. Now, complications of lymphedema include infection like lymphangitis, recurrent cellulitis, any bacterial or fungal infections. Malignancies include lymphangiosarcoma, Kaposi sarcoma related to HIV, malignant lymphoma, squamous cell carcinoma, melanoma, and we have the Stewart-Travis syndrome and cosmetic embarrassment. Treatment and management, we have surgical and non-surgical. This one is non-surgical. We can try decongestive lymphedema therapy. We can try compression, like compression garments and stockings. We can try multi-layer lymphedema bandaging, elevation, skincare, such as fungal ointments to treat any type of ulcerations, or proper skincare with moisturizing the skin and stuff. We can try manual lymphatic drainage. Compression pumps and therapy are also available. Pneumatic compression therapy is available, and exercise and weight loss is highly recommended. Surgical management, we can do an angioplasty alone. We can try stenting of the subclavian vein in cases of significant recall, like severe cases. We can try a bypass around the occlusion. We also have lymphatico-venous anastomosis, LVA, lymphatico-lymphatic bypass, lymph node transfer, resection or reduction, and lastly, suction-assisted protein lipectomy. Thank you.
Any questions from the audience or from the Zoom meeting? That's important to note that usually when you have venous disease in patients who are renal patients have been on dialysis, usually before they get on dialysis in the US, they typically may have had catheters put in the chest. And usually if the catheter is placed in the subclavian vein, they run the risk down the road of developing subclavian vein stenosis. And that can be the nidus for the edema. This particular patient had catheters put in the past. He had successful AV fissions, left upper extremity. And as part of his advanced stage, he was successful in getting a renal transplant. So he's really out of that case where he needs a catheter put in his chest, but he already had that before. And the stenosis was occurring on the side that did not have the fistula. So we went ahead and did what we had to do with great results. We'd seen him a week later and he was actually doing better. The mastitis area on the right and the right extremity edema were actually receding. So that's very good. Any questions?
Yeah, I have one. So I guess in the last slide they were mentioning, or she was mentioning like a lymphatics to blood vessel anastomosis. So like I wasn't too familiar with that. Like, is there like some way like fat can leak into the blood, or is it like I don't know if it, like I haven't heard of that one.
Yeah, it's not commonly performed. It's rarely done, usually done in university settings. And usually lymphatic system care, we typically get away with the non-invasive options. But for persons with severe disease, you may have to look at that. But usually in a community hospital setting, those technologies not really come. But yes, a few physicians worldwide do that. So we have searched them out. Okay, so we're making great progress. And so far, I'd like to congratulate you all for doing a great job. Nice job to all of you. And would come in with our next speaker. Thank you, Doctor. We'll get you loaded and we'll get you introduced.
Use the restroom, but
and we do have some water. You want water, some in there right there. And we have something coming for you soon. So our next speaker will be talking about minimally invasive procedure in PAD. And this is student Dr. Aslam Hussain, and he will be presenting shortly. All right, Dr. Aslam.
All right, hello everyone. My name is Aslam Hussain, currently a third-year medical student working with Dr. Oye. So today I'll be presenting a case study on minimally invasive procedure that we did in the OR. And it was used to treat a 61-year-old male patient with bilateral femoral popliteal occlusion. So we'll go through diagnostic findings, the procedure performed, and the outcomes achieved. So our patient is a 61-year-old male who presented with significant pain in his lower extremities, particularly when walking, and initial imaging using CT angiography revealed a bilateral femoral popliteal occlusion. So given the severity of the symptoms, we decided to focus our initial treatment on the left lower extremity, as the patient complained about the left being more severe. So we did some pre-procedure imaging with an arteriogram, and this provided crucial insights into the patient's vascular status, which was needed. So we found that the aorta and renal arteries were patent, meaning they were open and free of blockage. However, there was an occlusion in the left iliac artery, while the right iliac artery remained patent. So moving on to the left lower extremity, we observed a faint flow through the superficial femoral artery, or SFA, and total occlusion was identified in the distal segment of the SFA. So this image clearly shows that there is a patent aorta and patent renal arteries, confirming that these vessels are unobstructed. In this image, you can see the occlusion in the left iliac artery, while the right iliac artery remained patent, indicating an uneven distribution of arterial blockages. So now we did a rundown on the right lower extremity before we moved on to the left, and this also showed some faint superficial femoral artery, as well as the diminished blood flow. And then same here on the right side, we do see a total occlusion in the distal SFA, but again, we decided to go to the left side because of the patient's symptoms. So during the procedure, we executed a crossover from the right iliac to the left iliac artery. So imaging does show a robust 2 vessel profunda arteries, and there was a diminished appearance of the superficial femoral artery. So here's that crossover we did. So yeah, that we cross over from the right iliac to the left iliac, and this allowed us to access target on the left side. And then you can see the 2 vessel profunda arteries as well as diminished SFA.
So if you go right there, hold on right there. So see where the arrow on the point is the origin of the SFA right there. And then the 2 profunda more lateral. So profunda right now looks robust because of the chronic occlusion of the SFA. Okay.
Indeed. Okay, moving on. And then so
depiction, same thing, just magnified. The origin of the SFA again, you can see is very small, and the 2 profunda arteries very nicely robust. Okay.
right. And then so our observations indicated collateral flow between the profunda and superficial femoral arteries. This collateral circulation is critical as it provides an alternative pathway for blood flow when the main vessels are blocked. So we also observed flow through the distal SFA to the popliteal artery with a 3 vessel runoff, ensuring perfusion to the lower leg. So here, this image demonstrates the collateral flow between the profunda and the superficial femoral arteries. So a compensatory mechanism that helps maintain blood supply to the leg. And then here we can see the flow through the distal SFA to the popliteal artery, showing a 3-vessel runoff. This indicates that despite the blockages, blood is still reaching the lower extremities through smaller secondary vessels. So SFA cannulation. We then proceeded with the cannulation of the SFA at its origin. So the guide wire was positioned and confirmed using aerial projections. This step is crucial to gain access for further intervention. And findings indicated a total occlusion with some reconstitution just above the knee. So this image over here, it shows the cannulation of the SFA using a guide wire, and this helped us navigate towards the occluded area. Image on the left shows the cannulation of the SFA, while the right side shows the total occlusion. So you can see the guide wire in place, confirming the total occlusion. And then on the right side, we see the reconstituted segment of the fem-pop artery above the knee. So collateral branch and access. So we navigated through the collateral branch to regain access to the patent popliteal artery. Fluoroscopy was employed to visualize and confirm the catheter's position in the popliteal segment, ensuring the accuracy of our intervention. So catheter into the patent popliteal. So this image shows that the catheter is successfully positioned within the patent popliteal artery, enabling the next steps. So next, we then performed a balloon angioplasty using a Mustang balloon with a 0.35-inch platform to improve initial flow. Subsequently, we used a shockwave intravascular lithotripsy balloon to treat the entire SFA segment, particularly targeting calcified plaque. So these images over here capture the initial use of the Mustang balloon to achieve flow improvement within the occluded segment. And then here you can see the intravascular shockwave lithotripsy with over here with the graduated markers to precisely target the calcified plaques. And we were able to treat the entire segment of the SFA, restoring the robust blood flow. And then post-procedure imaging showed a significant improvement. The completion arteriogram demonstrated improved flow in the SFA, with a 3-vessel runoff extending to the ankle, a marked improvement compared to the pre-treatment condition. So here we can see the treated segment of the SFA where blood has significantly improved post-intervention. And again, final flow. This image shows final flow results, showing the previously diseased artery is now much better. And then these images on the left, we have below the knee flow, and then on the right, we have ankle area flow. So also indicating successful revascularization. So the patient was discharged following a successful endovascular intervention using a completely percutaneous approach. He was administered 5,000 units of heparin and monitored for 2 hours before being safely discharged. The patient will be followed up to assess his long-term recovery and ensure no complications arise. So in conclusion, this case demonstrates the effectiveness of a minimally invasive approach using endovascular techniques to manage peripheral arterial disease. The procedure successfully improved arterial flow, leading to positive patient outcome and rapid recovery. This method highlights the advantages of modern vascular intervention techniques. Thank you.
Nice job. Any questions for Dr. Smith? Essentially, again, this patient's main issues did demonstrate a complete occlusion of the proximal to mid SFA with reconstitution of the papillary artery above the knee. And treatment options again would be endovascular option if you can from above, which we did from right to left. If you could not do that, the other option you could go from the left arm down. And the third option, which may require hybrid intervention, would be even not, maybe not a hybrid. You could also go from the pedal, from the ankle of foot, and come cephalad if you're able to cross it. Usually, when you come retrograde from the lower extremities, it's easier to cannulate the true lumen of the vessel. But with some creativity using multiple wires and catheters, we're able to actually get a true lumen from the top, which made it a lot easier. So we only had one stick on the right groin of 6-French sheath, then exchanged to a long 6-French sheath. Once the wire was in place, we then offered an endovascular intervention. He mentioned the things to worry about here is you have an arterial occlusion, and if you were to even think about doing intravascular literature, such as a shockwave angioplasty, sometimes that wire is a 0.014-inch wire. It may be very, maybe not as robust in terms of the strength, and your balloon may not track down. So we just went ahead and pre-ballooned because we had an 0.35-inch wire, which is thicker. We pre-ballooned with the first balloon just to kind of open access a little bit, to ensure that when we did use the intravascular lithotripsy balloon, that it will track, because then we have to exchange to a 1.4-wire platform. So that went really well. Again, that's one of the new tools we have in our armamentarium of treating patients with PAD, the use of intravascular lithotripsy. It's a neat technique. We've had patients who've had fempop bypass in the past that were that came back with a occluded fempop bypass and were able to actually go back, and even though they've been bypassed before, go back to the native artery and with some luck go through the native artery that was bypassed, and then offer the intravascular lithotripsy with excellent result, where we didn't have to redo the bypass. So that's, and again, that particular situation was totally percutaneous, no cuts involved. So it does have great value. So we have to, again, we have all those tools. You have to decide when to take one particular tool from the toolbox. Sometimes I may go with plain balloon angioplasty. I definitely don't want to put stents in the iliac area, in the femoral fempop segment, unless absolutely necessary, as the case we did yesterday. If you recall, I don't know if you were there yesterday, we had a fairly, let's see, 73-year-old gentleman who had an aortic bifemoral, aortic by iliac aortic stent placed before, and he had the left limb of the stent that was occluded. He also had the right limb of the stent that was patent, but a stenosis right below where the endograft stent was, about 80% or so. It wasn't my case initially. So the surgeon ballooned and stented the right iliac with the intent to do a fen-phen bypass, which was done. Patient did well. Post-operatively, number 1, we thought the foot was slightly warm, but post-operative number 2, the foot became cold. He had a lot of pain. And so we decided to do a repeat CT angiogram, and discovered that he had about 70 or 80% stenosis below the origin of the left limb of the bypass. Because of that, we and also the test also did show that he had some profunda plaque also, and so again, so he was having more symptoms as a result of that. Treatment options at that point would be the right limb is patent, the iliac stent is still patent, so just address the left side because that's the symptomatic side. And in our minds, we're thinking, okay, we can go back and maybe do endovascular option and maybe do balloon angioplasty stenting of the proximal SFA below the bypass anastomosis, but that would not have solved this problem because it did have profunda plaque also. So the option we elected for was to take down the anastomosis of the femoral bypass left limb. We took that down and identified the SFA, superficial femoral artery, identified the profunda branch, then did endarterectomy and block clot removal, embolectomy of the profunda to restore flow through the profunda. Then we extended the arteriotomy on the SFA and took more plaque out. Then we patched it with a Gore-Tex patch, robust patch. Then we took the old fem bypass limb that was taken down, trimmed it again, and reattached it to the new patch with real good results initially from that surgical segment. Then we noticed after that he did not have did have pulses in his DP and PT area and in the ankle. Foot looked still ischemic. We then proceeded to make an incision below the knee popliteal. The popliteal artery was very diseased and small. We then made an arteriotomy and passed it. There was no flow coming through of significance, so we knew it was a problem. We put a Fogarty catheter up retrograde from the popliteal. That didn't see any clots per se, but the flow was still weak. Within the arteriogram, then discovered there was still residual plaque burden below the area of this extended patch. So, and this is a case where we did balloon angioplasty. We knew if we do balloon angioplasty alone, that would be inadequate. So this is a case where we had to put stent. So we selected stent, stented that area, then balloon that area would flow. Then we had great flow to the below knee segment. Again, we knew there was a problem because downstream we put Fogarty catheters through the anterior tibial and also through the posterior tibial. The balloons went down. We got a small amount of clot, but the balloons went down easily. Then we elected to repair the popliteal arteriotomy, which we did. Once we did that, we took our final test again with Doppler. There was still no pulses in the foot. So this guy, I mean, this is like many hours after the fact. It was a 9-hour surgery for limb salvage. So we then proceeded to make a posterior tibial incision at the ankle. Then the artery was small. We then put the balloon catheter retrograde again, remove some clot and got some flow. Then saw that the flow from posterior tibial was now okay going up. We went antegrade towards the foot. The balloon catheter size 2 foot catheter went down. We got some backflow. Then we patched that area again and waited for pulse. There was initial pulse, and pulse disappeared again. So we had to like stick that above the patch again, made an arteriotomy, did an embolectomy again, and got some more clots out with restricted flow. But now pulse has been present. The foot still looks somewhat ischemic, even though there's a posterior tibial pulse. We're now elected to explore the dorsalis pedis. So we made another incision in the top of the foot and found the dorsalis pedis artery, and we did embolectomy again going up. But what we had noticed when we did the posterior tibial artery arteriogram, we noted that the origin of the anterior tibial had already occluded. So it's a tough day. So now we have to now pass that wire through that embolectomy and then got some flow. Once we confirmed there was flow, that we didn't have to do any angioplasty or just in that area, then we put the wire down to the foot. Similarly, did the embolectomy on the dorsalis pedis area. Then we repaired the entry site and finally had pulses, DP and PT pulses. Long day. So patient now was transferred to the ICU, and about maybe 11:35 p.m. after 9 hours of surgery, get another call, patient's bleeding, then go back, take a look, and patient had tear in his bypass, which massive bleeding, had to control that in the ICU and restored flow, and saw him this morning, he's doing well. So those are the challenges of endovascular intervention sometimes. Challenges of open surgery, sometimes you do a surgical intervention and patients just have difficulties. And again, the end result is getting a flow to its lower extremity. If you don't, this patient will be subjected to definite amputation above the knee. So we're able to avoid that at this time. Hopefully it'll work for him. All right, so we're going to move on to one more presentation. All right. Any questions for Dr. Hussain from audience? Nope. Okay, good.
Oh, right here. Oh, oops. All right, there we go. Yeah, sorry, I don't use Mac. I'm not used to the. All right, and then now I need to share screen again.
Oh, that's fine.
It's sharing?
Yeah. You can just use the arrows up and down to go.
Okay. Can everyone's I think I clicked stop share though on Zoom, like before I got in here. Can people see this? Like that are remote? Can they see the presentation?
Dr. Shangare.
Yeah, we don't see the screen. It's not shared.
Okay.
It's not sure. Okay, hold on a second. Where are you? Let me open this up again.
Yeah, it should be here. Maybe click more or share.
Here it is. There it is. I was looking for it.
Thank you.
Okay, yeah, it's back.
Okay. And your presentation was.
Yep.
So you can just go through the.
Yeah, sounds good. All right. So my name's Amogh. I'm a fourth year medical student at Avalon School of Medicine. I'll be going over a case for a brachial artery pseudoaneurysm. We'll go through some background, talk about like epidemiology, risk factors, like how a person would present if they came in with a brachial artery aneurysm, and then also some workup and then treatment options for people with this condition. And then we'll also go over a recent case that we did here at RGH with Dr. Oye for a brachial artery pseudoaneurysm. And then we'll have a discussion as well based on kind of the technique we used, and in particular, the grafts. So we'll start off with risk factors for aneurysms. This can kind of apply to aneurysms in general. It doesn't really have to be brachial artery, but yeah, particularly brachial artery though is extremely rare when you consider all the aneurysms that can happen. It accounts for about 0.5% of all aneurysms, like compared to other locations. And some of the things that can cause aneurysms, there's trauma, like blunt trauma, but it can also be puncture trauma when someone uses IV drugs or is on some sort of chronic medical management that requires, chronic, needle access. And then infection as well, vasculitis, particularly Berger's and Kawasaki's, but I'm sure there's other vasculitides that can cause it. There can be genetic disorders, namely connective tissue. You can have like EDS or Marfan's, which Marfan's in particular, as you know, would be in the aorta predominantly. And then Kawasaki's and other common vasculitity that can cause aneurysms. Or sorry, NF. And then there's also prior surgeries that can lead to this, particularly AV fistulas. And, and with someone that needs ongoing dialysis, their fistula can lead to an aneurysm potentially. So yeah, how do you identify someone that comes in who has an aneurysm? So I guess the most common symptoms would be pain, due to, limited blood flow. So it could be claudication, but also in particular with this, the brachial artery, when you have a large enough aneurysm, it can actually compress the median nerve, causing paresthesias as well. On exam, you may feel a pulsatile mass, and even a thrill can be associated with erythema. And then as it gets worse, you can potentially start to have, poor flow. So you'll get digital ischemia, cyanosis, weak pulses, or perhaps asymmetric pulses, potentially even absent pulses when it gets really bad. It's also important to note that 33% of asymptomatic patients who have a pseudoaneurysm, which was just, I guess, incidentally identified through some other sort of imaging, are at risk of then progressing and becoming symptomatic. So even if you find that aneurysm, it's a good idea to keep an eye on it because it can progress. So how do you work this up? The most easy and least risk to the patient in terms of radiation would be an ultrasound, and that can confirm an aneurysm or a blockage. And then also you can follow up with the CTA. However, this is more for operative planning if you are considering that the patient needs further intervention. Here are some management options. When you do identify an aneurysm, you can do surgery, whether it's open or endovascular, and you can put in a stent or a graft. Even in terms of the graft, you can use the great saphenous vein, or use a biologic graft. And then there's, percutaneous methods, stents, coil embolization, ultrasound guided thrombin injection, and yeah, coil embolization. Not sure why I put it in there twice, but yeah, there's other options out there. And then open surgery is indicated in terms of if you're concerned that this is caused by trauma or there's potential rupture in the artery, or if there's concern for infection, you want to go ahead and do an open surgery. So now we'll get into the case done this week. So it was a 33-year-old male. He had a past history of IV drug abuse and Hep C. Upon admission, he was actually transferred here from another hospital, and on admission, he was found to have cellulitis. So he was started on some daptomycin and Zosyn. And even prior to him getting here, he had to already have his digits amputated due to the ischemia from more proximally on his brachial. So, obviously he had some pain, some redness. His labs were pretty good, actually, even given the cellulitis. His white counts were good. He just had a borderline CRP, 0.93, but that's nothing remarkable in terms of labs there. His CTA done did reveal a pseudoaneurysm. Here are kind of the dimensions of his brachial artery. You can see there was contrast accumulation, more on the distal part of that artery. And then he was also found to have a hematoma as well, adjacent to it. And you can see the measurements of that there. So that hematoma, and then on top of that, he had some cellulitis. So he was a good candidate for the open, versus percutaneous surgery. Here's the operative report, and then kind of also his post-op note. So when we went in there, we found that the brachial artery was macerated. Saphenous vein was not able to be secured, and we ended up using a 7x40 biologic graft. And then post-surgically, we unclamped and found that we were able to rescue the blood flow. He was also given some sodium bicarb and calcium chloride. And then, considering that he did have that infection, we also did a washout of the wound. And, post-op, he was doing well. And, cellulitis resolved. However, he was still discharged with the 10 days of augmentin. And wound cultures as well, which we took during the surgery, were negative. So yeah, I just wanted to briefly discuss kind of, I know I mentioned a bunch of different options, but in particular, I wanted to discuss, between taking the great saphenous vein to do to treat his aneurysm versus doing a graft, kind of the differences in outcomes. So I guess the main thing we look for whenever we do this sort of stent or any sort of procedure to improve blood flow is we want to make sure that that procedure doesn't then become stenotic again or have some blood flow issues. So this is what this is some data for the first line shows the numbers for the biologic versus autologous grafts. And this data was taken from research for carotid procedures in particular, not necessarily brachial. There wasn't enough research I found particularly for the brachial arteries. So the top line is for a paper looking at carotid procedures. So you can see 78 versus 85, although that might seem like it's something, it wasn't found to be significant. You can see the p-values there. There was also no difference in the ability to rescue a limb between using the biologic versus autologous graft. And also there was no difference in the need for a reintervention if something went wrong with the grafts. So yeah, you can see here some of the outcomes that they measured. However, so the top three lines, they were taken from papers for more on the upper extremity, upper half blood vessel, like procedures done on that. But lower extremity blood vessels, I did find some conflicting research where in the lower extremity in particular, they were found to have an increased loss of patency. And you can see the hazard ratios there. And this was between using the ratio would be between autologous and biologic. So in this situation, it's showing that the the autologous grafts are better in terms of staying more patent, and then also reducing the risk of the adverse like limb effects or limb events. So yeah, I think just looking at this data, just to conclude this and summarize, I think definitely there still needs to be more research done more on the upper extremity, and in particular, potentially the brachial artery as well, in isolation, because a lot of the data now looks at more carotids and other major vessels, and because of the fact that the brachial artery aneurysm and pseudoaneurysm is very rare, like I mentioned, only 0.5% of all aneurysms. I believe, there isn't much data out there, but it'd be interesting to see if there is a difference between the two types of grafts, with the big brachial artery in particular, though. So yeah, that's my presentation. These are some of the, we're excited if you guys want to look at the outcomes and stuff. Yeah.
Yeah, that's an interesting case again. A young fellow, but I suspect the overriding factor here is the patient was very vague as to the etiology of his problem. But at the time of surgery, it was evident that he had a linear tear of the brachial artery, and the brachial artery was the residual portion down the posterior wall was there. We thought we could do like a patch and be done with it, but turned around and it was just transected. So there could be some element of mycotic involvement, I suspect. But
So at that point, the possibility of patching was out of question. So you have to do a bypass. Now, we wanted to use the saphenous vein as the preferred choice. We prepped the groin and used ultrasound to look for the vein. It was just like so much edema and then how much of the vein we could use. So we decided at that point that the hand was getting really ischemic. I mean, it was really mottled. So we like to use the biological graft, which we luckily had available. So that's the autograft. So we're able to then use that. The benefit of that is ease of construction is there, and that's a lot easier, even better than the veins. You don't have to remove the valves like you already present the vein with the valves, it's much smaller. So it worked out quite well for him, and he did go home. So that's an interesting case, really interesting case. He had so much pain, but he got slightly better post surgery, and hopefully we prevent him from losing his upper extremity with a major amputation. Again, we also know that when it comes to revascularization of the upper lower extremity, the biggest concern is preventing amputation. Once you get amputation or you're about to get one, you will get depressed, no matter how psyched you are. So we typically tend to, in my practice, typically tend to wait, explain, have the patient understand where they're going, see if the pain is intractable for them, maybe even get psychological counseling prior to subjecting them to amputation. If you just go in, Mr. Jones, you have a problem with your leg, I'll cut your leg off. Mr. Jones, will get depressed, so that's what we tend to do. The patients will come to you, all cut it off, when get that point, you have to do it, but anyway, so that's what happened. So thank you again very much for the nice presentation from the young doctors. Any questions here? Dr. Shangre, you had a question.
Yes, let me make sure. Can you hear me?
Yes, we can.
All right, good. I just want to comment.
Dr. Shangre.
Okay, I just want to comment all the speakers did a very good job in making presentation. And I'm very grateful to Dr. Oye for teaching these young future great doctors how to present. Communication is very important in all aspects of life. Actually, your presentation are on the stage of chief resident that we are all familiar with. So if any of you need recommendation as you look for residency, please, I'd be glad to give you recommendation as high as possible, because I think you are all doing extremely well for all the knowledge you are gathering from Dr. Oye. It's a very good program, and I really enjoyed it very much. Thank you.
Thank you, Dr. Shangre. I appreciate it. Thank you. All right. So that's the benefit of getting ready as you improve your overall body of work. Medical school is not easy. You do a lot of studying, a lot of work, and then you have to worry about residency. Life just begins. Enjoy it now as a medical student. It gets worse. Become a resident. You still practice under the auspices of your trainer and or your hospital. Then you become an attendant, and life really gets worse, because now you have to take all the responsibilities. No person is going to shield you from the attorneys that are out there that take your license away, that think that you've done the greatest, worst job ever. So yeah, and patients are great to you. Then when something goes wrong, they become your mortal enemies. So those are things you have to, but it's a privilege to take care of patients. And we should look at the practice and art of medicine as such. So we should be very thankful to the patients for them giving us opportunity to treat them. We also should be able to communicate clearly to the patients what our intentions are if we're going to provide service to them, be it medical or surgical. And when complications do arise, be forthright with them. Tell them what the potential complications are. Do not hide anything from the patients or patients' families. Those are ways that can prevent you from getting into a bad situation. Again, we look forward to your excellent presentations and also additional presentations in the future. the global ground rounds occurs every 3 months or so. So if you have in your studies or practices down the road and you feel inclined to present an interesting case that you come across, you want to share that information with your colleagues here in America or across the world, there'll be an opportunity for you to do that. And we look forward to hearing from you. Our next global ground rounds will be in December. But our next major conference this year will modify it a little bit. It will be the endovascular conference for rural America and Africa, and that's next month. So we'll work on doing very concise presentations again, but also look at the possibility of making it very pragmatic. So for the persons on the other side of the pond, they will actually see the process of being done, so they can appreciate it further or better. So anyway, make sure you turn in all your presentations, flash drive, whatever, so it'll be a part of our panel records. Also store this information in the, you talk to Saad,
Yeah.
he stores the information so you can look at it in YouTube.
I'm also gonna post a link from the Zuma Foundation
Yeah.
for a forum.
Correct. So you can go back and look at the presentations, but you all did fantastic. I'm very proud of you all, and we'll make you all even better, and your recommendations look more shiny as we go on. Thank you so much. Well, I'd like to thank our folks on the Zoom network who have joined us today, and we look forward to seeing you on the next Global Ground Rounds in December, and hopefully also in the Endovascular Conference for Africa and rural America next month. Thank you so much. Thank you. And thank you for joining us, Dr. Shangre. Thank you.
Thank you, Dr. Oye. It was nice to be here.
Thank you, Chrislyn. All right, thank you so much. We'll look forward to seeing you soon. Thank you.
Thank you, Dr. Oye. Nice presentation. Thank you.
All right, thank you. Okay, so we have lunch, pizza for you all. Thank you. Nice job, man.
Maybe you can speak.